Rebonjour à tous. On va donc continuer et aller vers la dernière session de la matinée, qui est donc dédiée à l'élimination des viroses chroniques en santé publique, et dont les deux modérateurs seront Charlotte Boulllé de l'Université de Montpellier et Arnaud FONTANET de l'Institut Pasteur. Voilà, je vous donne la parole.
Bienvenue donc pour cette cinquième session, comme on vous l'a dit, constatée à l'élimination des viroses chroniques en santé publique. Je vais passer la parole à Arnaud pour présenter le premier intervenant.
Oui, bonjour. Donc, I will switch to English since our first lecturer is Imam from Egypt. My name is Arnaud Fontanet. I'm working at Institut Pasteur, where I'm the head of the Emerging Disease Epidemiology Unit. And it's really my pleasure today to welcome Imam for giving this first presentation on elimination of hepatitis C in Egypt. Imam is one of the top hepatologists of Egypt. And when you know the number of hepatologists in Egypt, you know it's quite an achievement. Imam also has been very supportive of the ANRS program we had in Egypt for 20 years. And he was a real architect in the elimination of hepatitis C as part of the National Committee for the Control of Viral Hepatitis in Egypt. So we are really fortunate to have him telling us his experience about this incredible adventure that the Egyptians have performed in order to almost eliminate hepatitis C from Egypt. Imam, you have 20 minutes of presentation, and there will be 5-10 minutes for questions.
Thank you very much, Arnaud, for your introduction, and thank you for inviting me and having me here. And over the next few minutes, I will share with you all the magnitude of the problem of hepatitis C in Egypt and what we did in the national program to treat and cure and eliminate hepatitis C. Until the year 2015-2016, Egypt had the highest prevalence of hepatitis C in the world. In 2015, our National Health Survey showed that the prevalence, the viremic prevalence was 7%, and the number of patients infected with hepatitis C in Egypt was around 5.5 million patients. This is a huge number. This is equal to the number of hepatitis C patients in all Europe, excluding Russia, all Western, Eastern, and Central Europe, and in these 38 countries, and despite our limited resources in Egypt. The disease burden was very high. At least 30,000 people died due to hepatitis C disease each year until the year 2015. And the disability was great. And the economic burden also was very large. Hepatitis C used to cost the country around 1.5% of the GDP in direct and indirect healthcare costs. We started a national treatment program in the year 2006. It was based on interferon therapy. Interferon in Egypt was not very effective. The cure rates with interferon in genotype 4 was less than 30%. And however, we established dedicated treatment centers all over the country to treat hepatitis C because interferon therapy was very complicated. So there were interferon treatment centers all over the country, and these centers were very effective when we started introducing the direct antiviral agents. In 2014, we managed to introduce sovosbuvir as the first direct antiviral at a huge reduced cost of $900 for a treatment course, which was close to 1% of the international prices. And we started a program in 2015. In 2016, we introduced locally manufactured generics, which were very much cheaper, and we started treating all patients. And initially, we used to prioritize treatment for patients with advanced fibrosis, and then when the treatment was more available, we treated everybody with hepatitis C. This graph shows the number of people starting treatment monthly from 2015. And initially, people who knew of their diagnosis came to be treated. We used to start around between 50 and 150,000 patients a month in the first 2 years. And then the numbers started decreasing because everybody who knew they had the disease had been treated. And as you see in the end of the graph, in the 2017, we ran out of patients aware of the diagnosis. But we estimated that there were at least 2 to 3 million people still living with hepatitis C who are unaware of the diagnosis, and we needed to find them and treat them if you wanted to eliminate the disease. By 2018, the treatment cost went down even further. It was, in Egypt, the cost was around $80 for a 12-week treatment course. And we decided, or the government decided, that let's do national screening, find all the patients and treat them once and for all. We decided to screen everybody over the age of 18, which was a population of 62.5 million if they came forward for screening, and screen all teenagers between the ages of 12 in middle and high school if their parents signed a consent that they approved that their children be screened. We changed the screening test from a blood test or an ELISA-based test to a rapid diagnostic test using a drop of blood. And we managed to negotiate the cost down to less than 60 cents a test. And we managed to reduce the viral load test from $25 to less than $5. And the treatment cost decreased even further to less than $50 for a 12-week treatment course. We started training trainers who again trained more trainers to train the teams that were going to use the screening tests. And we divided the country into 3 phases, each phase of 2 to 3 months. And each phase had between 7 and 11 states and a population between 18 and 25 million, target population. And there were between 4,000 and 6,000 screening sites in each phase. All hospitals in Egypt, all primary healthcare units, all rural health facilities participated in the screening. There was a huge media campaign, TVs, ads, billboards, messages everywhere, and the telephone companies or the mobile operators used to send millions of SMS messages urging people to go to screening. We had mobile units that went to mosques and churches for Friday prayers and Sunday Mass, to clubs and for soccer games and so on. And a person would come to a screening site. He could walk into any screening site. The sites operated from 9 to 9, 7 days a week, 30 days a month, over the 7 months of the screening. And they would have their data registered on a central database via cellular networks. And they would have a rapid test. Once the result is out, the result will be registered. And if they had antibodies, they will automatically have an appointment for further evaluation and treatment at one of the national treatment centers, the closest national treatment center to the screening site. Patients used to receive the treatment within 1 to 2 weeks maximum. And then at the end, if they came back for PCR for the proof of cure, they used to get what we called a certificate of cure to encourage them to come back for their follow-ups. This was the magnitude of the campaign. 15,000 healthcare facilities, around 60,000 healthcare workers, 20,000 medical teams, and the average daily flow over the 7 months was 240,000 persons coming for screening daily. This is the graph I showed you earlier, and with the start of screening, we the numbers of patients starting treatment increased to more than 200,000 patients a month, up from less than 5,000. Of the target of 62 million persons, 50 million came for screening voluntarily. The seroprevalence was 4.6%, or 2.2 million were seropositive. Of the 12 million target children, 7 million had their parents sign a consent and were screened, and the seroprevalence was 0.3%. All these were offered treatment, and this is the treatment cascade. If you look in the last few bars, 1.6 million were viremic. These were 1.5 million were treated in the national program, and the rest were treated in private practice. 1.2 million came for follow-up and proof of SVR, and of these, 98.8 were cured and had achieved an SVR. This is what we published a few years back in the New England Journal of Medicine. And we have a detailed breakdown of the prevalence of hepatitis C infection in every neighborhood in Egypt. And this bubble chart shows the number of patients and the prevalence of infection in each state. The size of the bubble shows the number, and the height shows the prevalence. And this heat map shows the prevalence in females in the upper part of the Nile Delta and the Nile Valley. And this shows the prevalence in males. And the prevalence in males was much higher than the prevalence in females. So of the 1.6 or 1.7 million who were treated in 2019, the recorded SVR was 98.8%. And since the start of the program in 2015, 4.2 million were treated, and the recorded SVR is 97% all over. And this was all using generics. So what is the impact? We calculated using modeling that the number of viremic now in Egypt would be less than 350,000, which is a 94% decrease compared to 2015. The prevalence would be 0.3%, which is also a 95.7% decrease. And the number of new cases will be around 6,000 to 7,000 cases a year, down from 130,000 new cases each year in 2015. This curve shows the viremic cases, the number of cases had we not done the screening test, and this is the impact of the national screening and treatment program. And we estimate that by the year 2030, we would have 1.2 million fewer cases, and we would have saved or prevented 180,000 new cases. This table shows the incidence in area in the Nile Delta that has been tested repeatedly over time. In 2005, the incidence was 610 per 100,000, or in the country that would have been 200,000 cases. A repeat incidence study in 2013 showed that the incidence would be 130,000 cases for the whole country. In 2018, in an area close to this site, showed that the incidence has decreased to 37 per 100,000. This was the impact of the first few years of the national treatment program without the national screening campaign. And I think the Pasteur Institute and Arnaud were involved in the first two studies. And our estimates now in by modeling show that the incidence would be, had dropped to 10 per 100,000. Liver cancer will decrease in Egypt, and we hope that our program will prevent by 2030 80,000 cases of liver cancer, and liver-related deaths will also be prevented to a large extent. And this year, the Ministry of Health did a national survey that showed that our modeling was correct, and the prevalence of hepatitis C in the 27 states was 0.4% viremic prevalence, which amounts to 330,000 people unaware of the diagnosis who have hepatitis C. As an economic impact of the campaign and the treatment, the total cost of the program in 2018-19 was $270 million US dollars. And to identify, treat, and cure an adult unaware of the diagnosis was at a cost of $114, and to identify and cure unaware viremic teenager was at a cost of $365. And for each dollar spent, we estimate that we will save $26 in direct and indirect costs by 2030. And this program, the whole program, will save the country $20 billion in the coming 20 years. This is unpublished data yet that shows the number of patients treated during the past 10 years since the introduction of the direct-acting antivirals in different countries. Egypt, in red, has the most number of patients treated globally. 4 times the number of the patients treated in the whole EU in the past 10 years were treated in Egypt, and 25% of the global number of hepatitis C patients treated. And in the years 2015 and 2019, Egypt treated more than half of the patients of hepatitis C treated all over the world. This table shows the WHO's HCV elimination validation criteria. And now that there are numerical criteria to verify elimination in a certain country. And we actually achieved all these criteria. The number of new cases are much less than 5 per 100,000. The number of new infections per year are down. The only element or item that was not achieved in Egypt is the numerical decrease in mortality, because we still have patients dying from the effect of the pool of hepatitis C, patients who still are living with liver cirrhosis and who develop liver cancer. Our mortality rate is close to 10 to 12 per 100,000, and will not go below 2 for the next 10 years. However, in last October, the WHO granted Egypt the first gold tier certificate of elimination, so we were officially announced the first country to be on the right track to eliminate hepatitis C. The key success factors are very important if we have to replicate this in other high prevalence countries. The social pressure was very important to convince the government or force the government to adopt a national treatment program. Political support was crucial. The government was totally behind the program. There was a huge media campaign. All the necessary resources were allocated from the start. We did not have any interruption in the program. Procurement and decision making was through a central body. We had the national committee did all the negotiations and the decisions of which items, which drugs, which tests. The availability of low-cost, simple, and rapid diagnostic was very important. If the rapid test was not there, we would not have achieved this program. The affordable therapy Definitely with our resources, we could not afford anything that's much more expensive. The single empowered body. The guidelines were very simple, and there was task shifting. We did not use specialized hepatologists. We relied on general practitioners, general physicians, general internists, and in some cases, nurses used to manage the patients. And all services were free to the patient. All investigations, tests, screening, treatment, follow-up, all was free to the patients on the expense of the state. And we did not check for fibrosis. Anybody who had viremia was treated. And the immediate linkage to care, patients on the spot, if they were seropositive, were referred to treatment. And treatment was available within 7 to 14 days maximum by the time they were evaluated further. So in conclusion, this was the largest disease screening campaign in the history of medicine. Nothing of this magnitude was ever done before. We have completed elimination of hepatitis C. Over 7 months, 57 million were screened. 2.3 million seropositives were identified, 1.6 million viremics. We treated more than 4 million patients with a very high cure rate using locally manufactured generics. And we were the first country to screen and treat the teenage population. And we are the first country to eliminate hepatitis C, despite we had the highest burden and one of the lowest resources or limited resources all around. And thank you very much for your attention. This is a photograph of Mathieu.
Thank you very much, Imam. Congratulations for all this work. Really impressive. I think we have already one question.
Okay. Thanks so much for your presentation. Very impressive program that you ran in Egypt. My question is about kids and teens. Specifically, why was it 3 times more expensive to treat teens than adults? And then why do you think you were able to get parental consent from only 50% of kids? What were some of the barriers or reasons for refusing screening for kids?
Your first question, why is it, was it more expensive to find and treat? Because the prevalence was much lower. We only found 30,000 among 12 million, and the prevalence in adults was higher, so it was much cheaper to find the adults by screening. The treatment was the same, the expense of treatment is the same. The cure rate in these children was 100%. So the extra cost was because of more screening. We necessitated parental consent because we screened them in schools. And we did not want there to be, hepatitis C is a very discriminatory disease in Egypt. We didn't want to announce the results in schools. So if the parents did not want to know, or the children to know their serostatus or their infection, we would not screen them. We only screened them if the parents signed the consent. And the teachers and the other students and the student himself did not know the result. We sent the result to the parents, and the treatments and the children were treated outside of the school. So it was a very, we tried everything we can so that nobody knows that the child was infected and treated.
Thanks.
Thank you very much. One thing, Imam, which I'm not sure you mentioned, is also that everything was digitalized. I mean, you had an ID for each individual living in the country, which was probably the national ID. And so you were able to know whether people had been treated in the past and their current status, which I think has been somewhat helpful in the follow-up and the monitoring of the campaign. I have one question is, I mean, what is impressive is the cost effectiveness of your program as well. I mean, you're showing that you are going to save $20 billion for the next 20 years. And so that even a country which has middle income, I mean, achieved to have excellent return on your investment, are you currently advising other countries in deploying the same type of mass treatment campaign?
The only country that's planning a mass treatment campaign is Pakistan. And they're always trying to start, but whenever they try to start, political things interfere. But we're advising them on what we did. However, we're helping other countries in Africa by providing medication and providing knowledge and assistance. We're giving free drugs to Chad, to Ghana, to South Sudan, and any other country in Africa that needs treatment for hepatitis C, we can help and offer. Now we are in talks with the Guinea and the Gambia for offering them treatment. However, hepatitis C is not a major problem in Africa. They have other problems, so I don't think that any other country is planning this national campaign. Rwanda has an excellent program. They started with Egypt, and they're doing very well on their own. And sometimes they were even more ahead of us before we started our national campaign.
Okay, thank you very much, Imam. And again, I think we can applaud you for this wonderful work.
Et maintenant, le plaisir d'introduire une intervention par Andrew PHILLIPS qui nous a enregistré une vidéo et nous rejoindra à la fin de cette vidéo pour partager son expérience et les questions avec la salle. Andrew PHILLIPS est professeur d'épidémiologie de biostatistique à UCL, où il a travaillé depuis longtemps sur le VIH et en particulier sur des études de coût-efficacité sur les différentes interventions dans le contexte des systèmes de santé des pays d'Afrique subsaharienne. Et il va nous présenter aujourd'hui l'intérêt des systèmes multi-agents dans l'analyse des systèmes de prévention justement contre le VIH.
Bonjour, je suis désolé, je ne parle pas français. So thank you very much for the invitation to speak here. I'm going to be talking about use of modelling to predict future HIV incidents with examples using the HIV synthesis model. So here's the outline of my talk. I'll firstly give a brief introduction to individual-based modelling for those not familiar with it. I'll then talk about briefly projected future incidents in East and Southern Africa. Then the main part of my presentation will be around understanding incidents in men who have sex with men in the UK and projecting the future. And then I'll briefly close by talking about capability building for modelling. So first, the brief introduction to individual-based modelling. I'd like you to think about how we can predict the implications of alternative health policies. If we are considering introducing a policy, we would like to have thought through the longer-term implications for health. So how can we do this? We're likely to have some evidence from randomized trials to inform the effectiveness of the interventions. But how do we translate this into predicting the long-term health outcomes of the various policy options? Now, we generally use models to predict these. Now, one type of model that I'm going to be talking about is individual-based models. So an individual-based model is designed to simulate the experiences of people in a population over time. So each time the model is run, it generates a simulated data set of variable values for a cohort of individuals representing the population of interest. So for example, here we have the population at a certain point in time. We have one row for each person, and we've got up to 10,000 people. And we have variable 1, variable 2, variable 3 on each person, and whether they're alive or dead. Now, specifying our model is then about how we specify how the values for each individual at the next time step, which might be 3 months later, but it could be any time step chosen, how those values are determined. So developing an individual-based model is mostly about specifying the expressions which determine how each variable is updated from one time step to the next. Now, in some individual-based models, the experience of each individual is entirely independent of the other individuals. In other models, a person's health experience can depend on others, and a common example of this is in modeling of infectious diseases. So this illustrates how we model infection within a population using an individual-based model. Each one of these lines represents one person being followed over time in our model. The black indicates the time when the line is entirely black, indicates that they've died. When it's partially black, it indicates that they're living with a disability. The yellow line indicates an infection. So we consider the outcomes of a whole population of people when modeling an infection, including those who could potentially be susceptible to infection, as well as those already infected. So an example of how that might work for an HIV model. A woman in our simulation has condomless sex with a man within a given age group. Given what we know about the prevalence of unsuppressed HIV in simulated men in that age group, and the risk of HIV transmission given unsuppressed HIV, we can calculate the probability that she becomes infected with HIV within the one model time step. Then we generate a random number between 0 and 1, and if this is below the probability value, then she is modeled to have acquired HIV. Okay, so for those of you that don't know about individual-based models, hopefully that gave you some sense of what they're about. I'm now going to turn to briefly talk about projection of future incidents in East and Southern Africa. I wanted to draw your attention to the HIV Modelling Consortium, which I'm currently responsible for coordinating. This is a collaboration between all major modelling groups working on HIV in the context of Sub-Saharan Africa, and you can see our website there. So this shows some results from one of the projects being conducted under the consortium. And this is a model comparison of projected incidence of HIV with continuation of current policies in the context of South Africa. And you can see that there's 5 modelling groups taking part in this. 2 of the models, HIV Synthesis and eMod-HIV, are individual-based models. The other 3 models, GOALS, Optima HIV, and Tembisa, are what's called compartmental models, where instead of updating individuals over time, we define compartments of people with certain characteristics, and we update how many people is there in that compartment and how that changes over time. So this illustrates how we've been using the various models to compare what we would expect to see under a sort of status quo of future HIV incidents. And there's a similar exercise underway also in the context of Zimbabwe with 4 of the same models and one other model, the Popper IBM model. But today I'm going to mainly be concentrating on this third point in the outline, which is understanding incidence in the UK, men who have sex with men, and projecting the future using the HIV synthesis model. And I'm going to be talking about work led by my colleague Valentina Cambiano on the effect of combination prevention strategies on HIV incidence among gay and bisexual men who have sex with men in the UK. So we used the HIV synthesis model for this work. Now each time the model is run, it generates a simulated population of men with variables updated every 3 months. So the time step in this case is 3 months. And those variables include age, number of condomless sex partners, whether they tested for HIV, use of oral PrEP, for example. The risk of acquiring HIV in someone depends on the viral load level in any condomless partners they have in that period. In HIV positive people, we model their viral load, the CD4 count, the use of specific antiretrovirals and specific drug resistance mutations. Risk of resistance is determined by current adherence and activity of the regimen. Risk of AIDS and death depends on the current CD4 count, the viral load, age, and ART status. Now, there was a range of different observed data items available. So there was quite a wide range of data available, and these are listed here, and these were available for multiple years. I'll just let you look at those. Now, I mentioned that individual-based models are largely determined by the expressions which determine how variables are updated over time from one time step to the next. And those expressions contain things we call parameters. Now, each time the model is run, there are outputs from the model which can be compared with the observed data to inform the model parameters. And this process of comparing model outputs with actual observed data is called calibration. Calibration in this case focused on 26 model parameters relating to condomless sex, HIV testing, PrEP, the effect of ART, and several others. So we determined distributions of plausible values for each parameter, with the breadth of the distribution reflecting the degree of perceived uncertainty. So we didn't just choose one value which we thought was the most likely. We considered a range of possible values that we thought were plausible. So the model was then run over 300,000 times, each time using a set of parameter values obtained by sampling at random from each of these distributions of parameters. Then the model outputs were compared with all of the different data items for each model run. So then for each model run of these 300,000, a score was derived that reflected the overall distance of the model outputs from the data. So for example, the solid line here indicates the outputs for one model run. The black dots represent the observed data on the cumulative number of HIV diagnoses in men who have sex with men in the UK. And you can see I've indicated here the distance from the line. So the sum of the distances of the model output for each model run is made. And we do the same for all of the different data points we're comparing with. So here we have the single model run and we have the proportion on antiretroviral therapy of those seen for care. And here we have the model output compared with data on the number of men on PrEP. And we do this for each calibration data point, for each data type. And possibly, in some cases, we use some weighting so that more importance is attached to being close to certain data points than others. So after running these 300,000 model runs and comparing for each one the outputs with the observed data to get an overall score for how close it was, we chose 300 model runs where the score was the lowest, where the data were closest to the model. So these graphs illustrate the calibration. So for the 300 runs that we chose, with the model outputs being closest to the observed data, this shows a few graphs of that comparison. The cumulative number of HIV diagnoses, the red line, is the median over those 300 model runs, and the shading represents the 90% range, and the filled dots represent the observed data. So you can see how close the model outputs are to the observed data for the cumulative number of HIV diagnoses and for the number of HIV diagnoses per year. And then similar graphs for the number seen for care for HIV and the proportion on antiretroviral treatment of those seen for care. And then we have the proportion with viral load suppression amongst those on antiretroviral treatment, and on the right, the number on PrEP. So that illustrates the calibration. So then these 300 model runs were used to infer aspects of the epidemic for which no data existed, such as the trend in the incidence of HIV over time. So this shows what we infer to have been the incidence of numbers of men infected with HIV in each of the years since the start of the epidemic. And the solid red line again is the median, and the shading represents the 90% range, reflecting our uncertainty. And you can see the inferred recent decline since about 2015 in incidence of new HIV infections. We then aimed to infer the effect that specific interventions, such as increased testing and immediate ART, PrEP, and condom use have had. To do this, concurrent counterfactual model runs were done, leaving out one or more of the interventions. So if you look here on the left, we have an example for PrEP. So the black line here, or the grey line, is the inferred actual HIV incidence that I've already shown. The blue line is what we would infer would have happened had PrEP not been introduced. On the right-hand side, we similarly again have the same grey line that we've seen. And in the purple line, we have what we infer would have happened had we not had the increase in testing and the starting of ART at any CD4 count. Then in this slide, on the left, again, the grey line is as before. The green line is what we infer would have happened had PrEP not been introduced and had we not taken this approach of increasing testing and starting ART in people regardless of CD4 count. And then on the right is what we infer would have happened if levels of condomless sex, so condom use, returned to 1980 levels in 2012. And what we infer from this is that PrEP and ART for prevention have both had a substantial effect of an approximately equal magnitude. So we can also run the model on for these 300 runs, and we can get a projection of where we think we're going in terms of numbers of new infections per year in men over the next 15 or so years. And you can see that we infer that currently there's around 400 new infections per year, and that will decline to just over 100 by 2041, although you can see there's a relatively large area of uncertainty, of course, as there would be expected for any future with any predictions. And this slide then shows what we would expect to happen if we make various changes now. So increases in HIV testing, increases in PrEP use, further decreases in condomless sex, and combinations of these. So you can see these various predictions over time. So I now turn to the last section on capability building for modelling. So modelling has the potential to help inform policy decision making and hence improve population health. But this depends, of course, on our models being as well informed as possible. To achieve this requires widespread engagement with modelling. It is critical that epidemiologists and clinical disease experts and others are able to understand modelling sufficiently to help to critique existing models and to help to improve them. We are aiming to develop material to help those with no prior experience learn about individual-based models by building, initially, simple models themselves. So this is an online course on building an individual-based model, and it uses the coding language Python. It can be accessed on the HIV Modelling Consortium website, hivmodelling.org, under resources. So this is it aims to be a highly accessible introduction to individual-based modelling to someone who has never done any coding before and has never built a model before. So any feedback that you can give us, if you go onto that website or show others that website, we would be very pleased to receive. So that's the end of my talk. I'd like to thank you for your attention, and I am available to answer any questions.
Il y a des questions. Oui, il y a une question en bas. Oh. Vous nous entendez? Are you hearing us?
Yes, I can hear you. Thank
there
you.
is one question coming from the room.
Hi.
Hear you. It's always a pleasure, and congratulations for your talk. Your modeling is extremely informative for the future, but I was also interested by your site on the back period. And perhaps I'm wrong, but I had the impression from your slopes that there was a kind of increase in the slope of the epidemics during the early 20s. So if am I right, what is your explanation? Is it because of loss of adhesion to preventative measures, or is it simply the diminution of deaths?
Thank you. So the increase in incidence in the early 2000s that you're referring to, I think, is in our model is due to somewhat reduction or increases in levels of condomless sex when antiretroviral treatment became available. So that's one potential kind of explanation for that. Yeah, I'd be interested to know if others have other suggestions.
Thank you.
One more question.
Thanks, Andrew, for your talk. I have two quick questions. My first is whether you had any identifiability issues with any of your 26 parameters, and if you could briefly mention any major limitations in the data that you had, because there was quite a long list, and I was wondering how recent it was, or if you could talk a bit about what data you wish you had to make your models better.
Yeah, thanks. I mean, to answer the second one, you know, I wish we had things like the surveys we have in sub-Saharan Africa on the population health impact assessments, random sample surveys, which would, you know, really help to inform us. But of course, that's not practical, and so we don't expect that. By and large, I would say that the data that the UK HSA collect is good and gives us quite a lot to go on with our calibration. The identifiability, not particularly, I wouldn't say, had major issues with identifiability. I'm trying to think back now to that, but I wouldn't say there were major issues with that being a. Yeah.
Okay, thank you.
Thank you.
I have one very naive non-modeling clinician question. In your approach based on individuals, is it possible to introduce something like clustering, like all individuals, they don't have the same comportment, and maybe some of them have higher frequency of contacts and don't have the same parameters as other? And is it possible to maybe that would need additional data on frequency of contact matrix or and prevalence or incidence in these different types of populations? Is it possible to combine those two approaches?
Yes, I mean, in the model as it stands, individuals do have, you know, one of the benefits of individual-based modeling is that individuals do have different numbers of exposures to HIV at any point in time. So we can include that kind of variability. Some individual-based models explicitly model, like, oh, this person in the model had sex with this person in the model. Whilst in our model, it's more about the fact that, as I tried to describe, that, oh, this person's having condomless sex. Who else is having condomless sex in this population who has the attributes of the person they're having condom sex with? We'll look at the likelihood of viral load being at different levels. Yeah, so I think individual-based models do give the potential for going further along the lines that you're saying. So yeah, I think that would be now there's disadvantages of individual-based models, but that I think would be an advantage of individual-based models that I would certainly see. Thank you.
Are there other questions from the room?
I may have one question for Andrew, and thank you very much for your presentation. I mean, you make those individual-based models look very attractive and even simple. And I would want to know, in your experience, what would be the main constraint or obstacle in building an individual-based model? I mean, compared to what used to be done with compartmental models, for instance.
Yeah, I mean, I didn't do a lot of building a compartmental model, so I can't so much compare the experience. But there's just so much to think about. I mean, I suppose is the you know, you suddenly have to think about every aspect of the epidemic. But you know, I find that really, I really like that. So you know, the main kind of constraint is just not having enough time to spend on. To spend on it, because it's such a time-consuming task, which is why I'm trying to get everyone else involved as well, because I think it's really worthwhile. But you know, we must recognise the limitations of what any one group can do with one model, and I'm sure that others could build better models. So yeah, thank you.
Thank you very much, Andrew, for joining us for questions. And I'll let the pitch to Arnaud.
Très bien, merci Charlotte, et merci beaucoup Andrew for this really very illuminating talk on individual-based modeling. Bien, et nous allons maintenant avoir la dernière présentation, qui sera une présentation plus courte, par Mathieu CASTRY de l'Université Paris Cité. Je crois que tu es aussi en postdoc, de ce que j'ai pu voir à Boston, mais tu nous en diras peut-être un peu plus. et qui va nous parler de la modélisation des stratégies de test and treat du VHC et de réduction des risques parmi les hommes ayant des relations sexuelles avec les hommes vivant avec le VIH en France.
Bonjour à toutes et à tous. Je voulais commencer déjà par remercier le comité d'organisation pour cette possibilité de présenter devant vous aujourd'hui. Donc, totalement dans la continuité des présentations précédentes, je vais vous parler de l'intérêt de la modélisation pour guider les stratégies d'élimination dans le cadre de maladies infectieuses, en l'illustrant par un travail qui avait été soutenu par la ANRS sur la transmission du virus de l'hépatite C parmi les hommes ayant des rapports sexuels avec des hommes vivant avec le VIH en France. Donc, de façon assez triviale, je voulais commencer par des éléments de définition, finalement de qu'est-ce qu'on dit quand on parle d'élimination. Donc on peut définir le contrôle d'une épidémie comme la baisse notamment de l'incidence à un niveau acceptable dans une zone géographique, l'élimination comme une baisse de l'incidence à 0 dans une zone géographique, et enfin l'éradication comme une baisse de l'incidence à 0 dans le monde entier. Effectivement, ça dépend des contextes aussi, et les définitions peuvent changer, et les objectifs d'élimination notamment aussi peuvent être différents. Dans le cadre du VHC, donc, on est dans un contexte thérapeutique hautement favorable, avec le traitement, les antiviraux à action directe, très efficaces et très bien tolérés, donc ce qui permet de réfléchir donc, réellement à l'impact de stratégies de dépistage et de traitement pour prévenir la transmission du virus au niveau populationnel. Donc, c'est dans ce contexte que l'OMS a émis des objectifs d'élimination des hépatites virales d'ici à 2030, et figurait parmi ces objectifs notamment une réduction de l'incidence de 90% entre 2015 et 2030. Alors c'était de l'ordre de 95% pour le virus de l'hépatite B et 80% pour le virus de l'hépatite C. Donc rapidement, revenons sur la définition contrôle-élimination. Donc en voyant un peu ces objectifs d'élimination de l'OMS, on est plutôt entre le contrôle et l'élimination. Et à vrai dire, l'OMS parle plutôt d'élimination en termes de problèmes de santé publique, en le définissant comme une réduction notamment de l'incidence à un niveau jugé négligeable en termes de santé publique. Par ailleurs, quand on parle d'élimination, il y a plusieurs approches pour atteindre l'élimination, là en l'occurrence du VHC. Donc, d'une part, la macroélimination, donc en s'intéressant à l'ensemble de la population, notamment par des stratégies de dépistage universelles de l'hépatite C dans la population générale, notamment ce qui a été présenté juste avant dans le cas de l'Égypte. Ou sinon, il y a également l'approche par microélimination, c'est-à-dire en ciblant des populations spécifiques, spécifiquement à risque d'infection et de transmission, en l'occurrence par le VHC. Donc, on peut penser notamment aux femmes enceintes pour limiter la transmission verticale, aux usagers de drogues injectables, ou bien aux hommes ayant des rapports sexuels avec des hommes, donc les HSH. Pardon. Ce qui nous amène au sujet donc de l'étude que je vais vous présenter aujourd'hui. Donc, on observe depuis le début des années 2000, en particulier dans les pays développés, une épidémie d'infection par le VHC parmi les HSH vivant avec le VIH. C'est une épidémie qui est principalement associée à des pratiques à risque dans un contexte sexuel, notamment l'usage de drogues récréatives pour les rapports sexuels, ou chemsex. Et par ailleurs, un autre élément de contexte, c'est que c'est une population qui, de par son infection VIH, est majoritairement liée aux soins, donc suivie à l'hôpital ou en ambulatoire pour son infection VIH. Et ça ouvre de réelles opportunités pour, d'une part, intensifier le dépistage du VHC et d'autre part aussi mettre en place ou améliorer des stratégies de réduction des risques et potentiellement donc atteindre la microélimination du VHC dans cette population. Donc à partir de là, nous on s'est posé la question de savoir quel était l'impact d'un dépistage renforcé associé à un traitement précoce de l'hépatite C dans cette population en France, en combinaison ou non avec des stratégies de réduction des risques. Quelques éléments de méthode. Donc, on a développé un modèle dynamique compartimental qui simulait de façon dynamique la transmission du VHC parmi les HSH vivant avec le VIH. Dans ce modèle, donc, on l'a stratifié en deux groupes à risque en considérant que le groupe à haut risque était donc les HSH engagés dans des pratiques de chemsex. Par ailleurs, il y avait un sous-modèle d'histoire naturelle de l'hépatite C, donc de l'infection aiguë en passant par les stades de fibrose hépatique jusqu'aux complications de la cirrhose. Et enfin, le modèle incluait donc à la fois le cascade de soins pour le VIH et le VHC. En ce qui concerne les stratégies évaluées, donc on est parti d'un scénario de référence censé représenter les pratiques actuelles, donc d'un dépistage annuel et d'une mise sous traitement rapide. Donc là, en fait, à partir de 2019, une mise sous traitement dans le mois suivant le diagnostic. Donc ici, on peut déjà parler de test and treat, puisque l'objectif c'est de tester pour traiter et limiter la transmission du VHC au niveau de la population. Donc après ce scénario de référence, donc on a évalué d'une part des stratégies de dépistage renforcées, donc 3 scénarios différents. Premièrement, dépistage tous les 6 mois. Deuxièmement, dépistage tous les 6 mois pour le groupe à faible risque et tous les 3 mois pour le groupe à haut risque. Et troisièmement, en dépistage tous les 3 mois pour l'ensemble de la population des HSH vivant avec le VIH. Et par ailleurs, donc, deuxièmement, des stratégies de réduction des risques en considérant donc une intervention de risk counseling lorsque les HSH étaient suivis annuellement à l'hôpital. Et donc on avait un peu deux scénarios, un scénario plutôt dit réaliste, avec là où la réduction des risques donc, permettait une réduction des infections et transmissions de 20%, et un scénario plutôt optimiste d'une réduction des risques de moins 50%. Et bien sûr, on a aussi évalué l'impact de stratégies combinant à la fois un dépistage renforcé et une réduction des risques. Alors, quelques éléments sur le résultat. Donc, premièrement, on avait estimé l'incidence des infections primaires dans cette population entre 2014 et 2017 à partir des données de la cohorte hospitalière FHDH, et on avait montré que l'incidence primaire du VHC dans cette population diminuait au cours de cette période, passant d'environ 1 pour 100 personnes année à 0,45 pour 100 personnes année. Et donc, à partir de ces estimations, ça nous a permis de calibrer le modèle, donc en fait d'estimer certains paramètres afin de coller au mieux à ces estimations de l'incidence primaire. C'est ce que vous pouvez voir ici sur la ligne en noir, qui représente donc les résultats du modèle pour le scénario de référence et les projections jusqu'en 2030. Et donc, on s'est notamment intéressé dans ce modèle en termes de résultats, à savoir l'impact des différentes stratégies en termes de réduction de l'incidence entre 2015 et 2030. Donc pour le scénario de référence, on avait une réduction de l'incidence au cours de cette période de 70%. Ensuite, si on se concentre sur les stratégies de dépistage renforcées ou bien d'une réduction des risques de moins 20% seulement, donc sans dépistage renforcé, là c'était plutôt de l'ordre de 76 à 77%. Plutôt 81 ou à 82% de réduction de l'incidence lorsqu'il s'agissait des stratégies combinant un dépistage renforcé et une réduction des risques de 20%. Et ensuite, pour les stratégies incluant une réduction des risques de 50%, seul ou avec le dépistage renforcé, on était plutôt là dans l'ordre de 85 à 87%. Là, ce que vous voyez, c'est les résultats dits en déterministe, c'est-à-dire en prenant une valeur unique, ou en tout cas la moyenne de ces valeurs pour chacun des paramètres du modèle. Et on a aussi testé la robustesse du modèle et de nos résultats en regardant en fait toute l'incertitude qu'il y avait autour des paramètres, en tirant des lois de probabilité pour chacun des paramètres. Et en fait, ça nous a notamment permis de regarder dans quelle était la probabilité d'atteindre 80% de réduction de l'incidence du VHC au cours entre 2015 et 2030. Donc pour le scénario de référence, là aussi, donc, on est à une probabilité de 24%. Là, je vous mets ensuite les résultats pour les autres stratégies, et je veux orienter votre attention ici sur la stratégie qui combine à la fois un dépistage renforcé et une réduction des risques de 20%, où là on est sur une probabilité d'atteindre cet objectif d'élimination entre 52 et 56%. On a par ailleurs, dans la continuité, donc, mené une étude de type coût-efficacité pour mettre en rapport donc, les coûts et les bénéfices cliniques des interventions. Le critère d'efficacité, c'était les QALY, donc les années de vie ajustées sur la qualité. Donc ça, c'est une métrique qui prend en compte à la fois les années de vie et la qualité de vie. L'outcome principal, c'était l'ICER, le ratio incrémental coût-efficacité, qui est défini comme la différence en termes de coût divisé par la différence en termes d'efficacité, donc ici de QALY, entre deux stratégies. Donc ça donne un résultat en termes d'euros par QALY. Et finalement, c'est ce qu'il faudrait dépenser pour obtenir un QALY supplémentaire. Ça, juger si une stratégie est coefficace, ça dépend de la propension à payer du décideur. Et nous, on considérait qu'une stratégie était coefficace si son ICER était inférieur à 3 fois le PIB par habitant. PIB par habitant en France étant environ à 33 000 euros. Et pour cette étude coefficacité, on s'est principalement focalisé sur des stratégies de réduction des risques de moins 20%, donc plutôt le scénario dit réaliste. Alors, on a évalué plein de stratégies, je n'ai pas le temps de vous les montrer aujourd'hui. Je vais vous montrer simplement les stratégies qui ne sont pas dominées, qui sont plutôt coût-efficaces. Donc, pour le scénario de référence, on a calculé donc, des coûts et des QALY. Donc, comparé à ce scénario, donc, une réduction des risques de 20%, cette stratégie de réduction des risques seulement, est dite cost saving, c'est-à-dire qu'elle était moins coûteuse et plus efficace. Et ensuite, à partir de cette stratégie, inclure en plus de la réduction des risques un dépistage tous les 6 mois, donc donner un ICER d'environ 61 000 euros par QALY, donc c'est à peu près 2 fois le PIB par habitant, et à partir de là, donc on a jugé que c'était une stratégie potentiellement coût-efficace. Donc, pour conclure sur ce travail, donc, ce qu'on a montré d'une part, c'est qu'il y avait déjà un impact marqué des pratiques et des recommandations actuelles en termes de réduction de l'incidence et aussi de la prévalence du VHC dans cette population. Et on a mis en évidence l'importance de la réduction des risques, des stratégies de réduction des risques pour atteindre les objectifs d'élimination, et notamment aussi le fait que cette stratégie était potentiellement coût-efficace lorsqu'associée à un dépistage du VHC plus renforcé. En plus globalement, la raison pour laquelle j'ai décidé de parler de ce travail, c'était pour un peu mettre en évidence l'importance de la modélisation mathématique pour l'aide à la décision. Parce que ça permet donc d'une part de projeter des résultats à long terme au niveau populationnel en prenant en compte les pratiques actuelles et à partir de là aussi donc d'identifier les interventions qui permettraient potentiellement d'atteindre les objectifs d'élimination ici du VHC et aussi parmi elles en fait lesquelles sont les plus efficientes avec l'étude type coût-efficacité. Et alors ensuite on s'éloigne des virus chroniques mais dans la continuité de ce travail on est également en train aussi de faire un travail donc, soutenu par la ANRS qui porte sur la transmission des IST bactériennes parmi l'ensemble des HSH en France, notamment pour évaluer des stratégies de prévention biomédicale, en particulier l'utilisation de la doxycycline en prophylaxie post-exposition. Alors bien sûr, c'est un travail qui s'inscrit parmi pléthore d'études qui portent sur donc, la modélisation du VHC dans différentes populations, dans différents contextes, afin d'identifier les stratégies d'élimination qui pourraient marcher. Et voilà, avec différents types de modèles différents, et notamment aussi pas mal de modèles qui questionnent les métriques en termes d'objectifs d'élimination du VHC. Là, je vous ai montré, c'est un exemple avec un objectif spécifique sur l'incidence. Voilà, il peut y en avoir plusieurs également. Je vous remercie, je voulais également aussi remercier mes collaborateurs.
Merci beaucoup. Est-ce qu'il y a des questions dans la salle? Are there any questions in the room? Moi, j'avais juste une question pour mon information personnelle. Le coût du traitement VHC est de combien dans...
Ah, exactement, là, je sais plus pour un traitement de 12 semaines comme ça, de tête, je ne sais plus exactement.
En tout cas, plus cher qu'en Égypte.
Oui.
Ah, une question ici.
Oui, moi j'avais une question sur le. J'ai pas bien compris comment on calcule un pourcentage de réduction des risques. C'est à partir de quoi? Qu'est-ce qui est défini comment?
Pour pourcentage de réduction des risques, alors nous on avait, comme j'ai dit en fait, on a stratifié le modèle en deux populations à risque, donc un groupe à faible risque et un groupe à haut risque. Et on avait pris en compte un risque relatif d'infection et de transmission du VHC pour le groupe à haut risque, donc les HSH engagés dans des pratiques de chemsex, comparé au groupe à faible risque. Et donc les stratégies, par exemple quand je dis réduction des risques de 20%, c'est une stratégie qui permettait de réduire de 20% ce risque relatif plus élevé d'infection et de transmission pour le groupe à haut risque comparé au groupe à faible risque. Ce n'est pas exactement le pourcentage de chemsex, parce qu'il y avait, donc on incluait dans le modèle donc une part de HSH engagée dans des pratiques de chemsex, et en fait le modèle avait un modèle de transmission comme ça, on paramètre notamment le taux de transmission, et en fait le taux de transmission était différent pour le groupe à faible risque et pour le groupe à haut risque, et on considérait donc pour les individus pratiquant le chemsex que ce taux de transmission était diminué de 20 ou de 50%.
Il n'y a pas d'autres questions. On va conclure cette 5e session. On se retrouve à 13h50, il me semble. Bon appétit à tous.